Hello and welcome back to Fertility Fact or Fiction, our show where we review every week a new topic, try and bring the truth out to our patients and friends, and play really loud background with me speaking at the same time. So welcome to the show. We are super excited to be back again. We've got a really interesting topic that I think is critical for a lot of people to be aware of, and we're going to review that for everything. And talk about what all the various ups and downs are. The topic tonight is going to be on cesarean section and whether having a cesarean section impacts your chances of success when you are trying again later on with assisted reproductive technology. So hopefully you've all had a chance to jump on board. We usually give all of our viewers a few minutes to jump on. Grab a cup of coffee or tea and get ready for an interesting show. You can always ask your questions at any point in time during the show, and we try and go kind of first come, first serve. We've got a fairly brief talk tonight, probably only take us about 10 minutes to go through the topic at hand, and then we'll jump right into the questions for you. We're not sure how many of our Canadian friends will be joining us because it's election night in Canada for our federal elections. So we will be choosing a new or recycled prime minister. So we'll see who gets selected. But hopefully everybody's had a chance to vote. And if you're watching the show, please make sure you like, comment, and subscribe on any of our social media platforms. So we're on YouTube, on Facebook, on Twitter, and on Instagram, where we are constantly posting videos and shows and all sorts of different things. And I know we put up our 5 biggest lies about COVID vaccine previously, but I don't think it actually made it up the way I wanted it to because there was a glitch. So we'll probably put that up again soon. I'm just reviewing it and renewing it to add some additional new information for you. So the topic tonight is cesarean section on assisted reproductive outcomes, a systematic review and meta-analysis. So this is from a Chinese group in Central South University, Changsha, China. And so it's an interesting study because they took all of the previous analyses, combined them together in this meta-analysis to determine if you have had a previous cesarean section, does that increase or decrease your chances of success later on when you're doing either IUI or IVF? And then they broke it down into clinical pregnancy, live birth rate, miscarriage, stillbirth, and preterm labor and delivery. So interesting study. Did you have a chance to pull up the tables? I'm not sure.
If you didn't tell me what to, but I have them.
Yeah,
so ready for you.
Did you get that one up there?
I can get it for you.
Yeah. So I'll just show you kind of how they found their data, and I'll give you their selection criteria as well. So they wanted to look mainly at IVF and compare it in patients that did not have a cesarean versus patients that did have a cesarean. So the outcomes they looked at, like I said, were clinical pregnancy, live birth rate, and then those were the primary outcomes. Secondary outcomes were implantation rate, miscarriage rate, ectopic pregnancy, the number of eggs that you would retrieve subsequently, endometrial thickness, difficult transfers, preterm birth rate, and stillbirth rate. So all of those things are included in there. And then in order to find the studies, they just wanted to make sure that essentially they were randomized controlled trials or as close to it as possible, that they had a control and a comparison group. So basically vaginal birth versus cesarean sections. And that they had the information on the outcomes that they were looking at, which was live birth or clinical pregnancy. So they started out with 754 studies. They found none additional from investigation of those studies. None of them were duplicated, which is actually uncommon. Usually there are. And then they had to exclude 733 because they didn't meet their inclusion criteria. So it is a huge cutout of the number of studies and people that were involved. They ended up with 21, and then they excluded 14 more because some of them didn't have a control group. They were just observational. Some of them were just reviews, and some of them had incomplete data. So they ended up in total with 7 studies, and then within each category of what they were looking for, they had to limit it to different numbers, anywhere from a low of 3, which was for one outcome up to the maximum number of 7 for the majority of outcomes. So what did they find? So we'll go to, I think it's table, well, this figure 2. You got that one there. So figure 2 shows that when they did the study analyzing a comparison between the clinical pregnancy rate of patients that had had a previous cesarean section versus those who had had previous vaginal births, there was a 14% decrease overall that was statistically significant between the two groups. In other words, if you had had a previous cesarean section, your chance of succeeding after infertility treatment with IVF was 14% lower than if you had had a vaginal delivery. So why is this important, the whole topic? Why is the whole topic important? The topic is important because we get loads of patients that are worried about having vaginal delivery. So they come in and they say, I want a cesarean section because they think it's safer or it has less pain or it's a faster recovery or whatever the case is. So the reality is all of those things are actually not true. Cesarean section is not safer. It's actually more risky for you and it's more risky for your baby. There's a higher chance of the baby ending up in the neonatal intensive care unit when you have an elective cesarean section than when you have a vaginal delivery. Same thing for the moms, higher risks of infection, anesthetic complications, bleeding, and injury to internal organs. You basically can't really injure any internal organs when you have a vaginal delivery unless you have a very severe tear, whereas with the cesarean section, there's all sorts of opportunities for injuries, both in that particular surgery and later on, if you have another pregnancy, the placenta can stick or become difficult to come off or go very low and so on. So it's a huge topic because we get requests for cesarean sections every day, all the time, but it's super important to tell patients that it is not critical for them to have a cesarean section. And if they're fertility patients, it's particularly important for them not to do it because it will decrease their chances of clinical pregnancy. What about live birth? Live birth is obviously the holy grail. So that's figure 3. If you look at figure 3, you can see that when they added up all of those different studies that were in there and they were able to include all 7 of the studies, again, it's a 20% decrease in live birth when you've had previous cesarean section. So if your delivery mode was a cesarean versus a vaginal delivery, you had a 20% decrease in success. So again, if you're someone that's going through IVF, you get pregnant, if you need a C-section, okay, we get it. But if you've had an elective cesarean section, if you're choosing to do it, you're actually compromising your chances of success with your next pregnancy if you're trying to get pregnant again. How significant are these findings? Because the numbers were fairly robust, the total number of patients was 2,352 in the cesarean group and 3,296 in the vaginal delivery group. You're actually looking at extremely, extremely significant values. It's less than 0.00001 for the p-value, which is extremely, extremely significant findings. So these are very tight confidence intervals. It shows that the results are reliable. And when they looked at the data that they were entering into the meta-analysis, there was some heterogeneity, as we say, which means the studies weren't all exactly the same. So they're a little hard to compare, but it was reasonable enough to get a pretty decent answer out of it. So the next thing that they looked at was whether there was a difference in the other outcomes, so the secondary outcomes, which were things like miscarriage and ectopic pregnancy and so on. And when they looked at the miscarriage rate was actually different between the groups, with the miscarriage rate being higher in the group that had had cesarean section. How high? It was 39% higher if you had had a cesarean section than if you had not had a cesarean section. Possible reasons: the indentation from where the scar of the C-section is can often harbor old blood from the menstrual cycle, cause infection, and the infection can lead to miscarriage. There may be alterations in blood flow to the uterus. There could be adhesion formation. There may be some underlying inflammatory mechanism we're not even aware of. So there are all sorts of reasons for this that could lead to an increased risk of miscarriage. And I'm not aware of any studies specifically that have looked at it in this much detail before examining that risk of miscarriage in relation to cesarean section, specifically for patients undergoing IVF. So this is hugely valuable data. And again, that was extremely, extremely significant, less than 0.00001. So very, very significant findings. When they looked at the other outcomes, preterm birth, ectopic pregnancy, stillbirth, number of eggs needed, and so on, there actually was no difference. So they showed that none of those outcomes are related to a cesarean, but your most important outcomes, which are clinical pregnancy, live birth, and miscarriage rate, were directly related with having a cesarean section. So for all those of you who are thinking possibly about an elective cesarean section and just kind of diving right into it because you think it's safer or it's better, on top of all the fetal risks and the maternal risks, remember that based on this study, you're actually potentially compromising your future fertility as well. And it will reduce your chances of clinical pregnancy by 14%. It'll reduce your chances of live birth by 20%, and it'll increase your chances of miscarriage by 39%. Huge, huge numbers, very, very significant, something that really needs to be calculated when you're deciding what you want to do. Now, if you have to have a cesarean section, you have to have a cesarean section. Examples, placenta previa, a breech pregnancy if you're working in a center where they don't feel comfortable delivering breeches or you feel it's unsafe. If you have, something like fibroids that are blocking the outlet, or if there's some other kind of complication like fetal distress and so on. All of those are valid reasons to have an urgent or elective cesarean section. But if you're choosing to have a cesarean without even trying to labor, and you've never had a cesarean before, that's probably not the right decision if you are going through fertility problems already, because it's going to aggravate your fertility problems when you go to try again next time. So fact or fiction, is it a fact or a fiction that cesarean sections can alter your outcomes? It's actually a fact. Having a previous cesarean section will significantly alter your chances of success and increase your chances of miscarriage. And for that reason alone, it is strongly advised to not have an elective cesarean section. So thank you for joining us for that super brief but very, very necessary topic on C-sections. I think we'll probably turn that into a post as well and put it out there for people to take a look at. And it'll be up on our YouTube channel. Remember, like, comment, and subscribe. And I'm going to start responding to a lot of our YouTube questions shortly. So on a daily basis, we'll be posting responses up there as we do to Instagram all the time. For all those of you that are already liking, sharing, and commenting, thank you. And keep that up because it's huge for us and drives us on to keep doing more and more. So thank you very much for joining that part of the show. We're going to take your questions live now, and I'll turn it over to Tarek, who is going to start asking the questions.
So a question from one of your ERA videos on YouTube.
Yeah.
So the subscriber says, really sorry to miss this video yesterday live, and thanks so much for your ERA video. I canceled my ERA test after watching it. Can I ask a question?
Sure.
As I've got a horrible feeling my clinic has been doing my FETs a day early, but they don't seem to want to engage when I ask them about it. I know different women will vary, but can I ask what the usual day is for transferring a 5-day-old frozen embryo? My clinic does it on LH surge plus 5 days, 4 days past ovulation. But I know that other clinics and all the papers I've read say LH plus 6, 5 DPO is more usual. These are the last genetic embryos I'll have. So I really want to give them the best chance I can. Thank you.
Yeah, it's usually LH plus 7 or LH plus 6. I've never heard of LH plus 5. That is too early. You will have endometrial asynchrony, where the lining is not actually lined up with the embryo. So a day 5 embryo can go in after 5 or 6 days of exposure to progesterone. So if you think of it in terms of ovulation, once you've ovulated, you start producing progesterone, probably shortly thereafter. So you would have to complete 5 days after the ovulation and then transfer on the morning of the 6th day, or a day 5 can go in after 6 days of progesterone exposure. So complete the 6 days of exposure of progesterone and then on the 7th day. To do LH plus 5 is crazy wrong for a day 5 or a day 6 embryo. So I'm not sure why on earth they would be doing that. And that makes absolutely no sense whatsoever. Like nobody that I know of is doing that. Literally no one. So I'm sorry you're going through that. I would strongly caution you against continuing with that center, or just push for yourself and say, I want to do it on my own time. I don't do natural cycles that much, so we don't follow the LH in particular. We typically just go straight into a medicated cycle because I find them easier to control. And when you look at the literature on this, and they just published another study actually the other day, there is no difference. Natural or medicated has the same success rate. So it's probably very reasonable for you to just be doing a medicated cycle where you can time everything and decide when you're starting your progesterone. That way you don't need to worry about it.
What is the difference between an SSG and an HSG?
I've never heard of an SSG. So if you're thinking of a saline infusion sonohystogram, that's an ultrasound done where we flush in hopefully warm saline into the uterus and do a 3D ultrasound to see what the shape of the uterus is, get information on your tubes, get information on your ovaries, your cervix, the inside and the outside of the uterus. You can pretty much get everything you need. If you're talking about an HSG, that's a hysterosalpingogram. So that's when we inject radio opaque dye, in other words, dye that shows up on an X-ray, into your uterus, and all we can get information about is the inside of your uterus and whether or not your tubes are open. So any of you who are regulars on the show will know that I am a very strong advocate for not doing hysterosalpingograms because A, they don't give you as much information, B, they're usually quite uncomfortable, and C, you're getting basically an X-ray exposure, which is unnecessary. A properly done saline infusion sonohystogram is painless, easy, and gives you way more information, and also gives you information about the tubes. For some reason, there's a myth out there that you can't get information about whether or not your tubes are open from an SIS, and the truth is you absolutely can. We do it 6 or 7 times a day. So I'm not sure where that myth is coming from or who it's driven by, but it is incorrect. You easily can get the information you need from an SIS, much more so than you can from an HSG. The video we have on YouTube, I think it's our second most popular video. If you go to the popular videos or popular uploads, the second one is me actually doing a saline infusion sonohystogram live. And that now has 25,000 views. So check that out, and it'll be 25,001, I guess. And have a look at that video because you'll see how much info we get and how easy it is to see what we want to see.
A comment. It would be useful to know what is the percent of men that are not diagnosed with male infertility because the current tests are not comprehensive.
Oh. Well, I guess I'd throw that back and say it's impossible to diagnose something if we're not diagnosing it. But we know overall that approximately 40% of infertile couples are experiencing it because of male factor, 40% because of female factor, and about 20% because of both. As far as male factor is concerned, we here do fairly extensive testing. So we do your full hormone panel, we do cholesterol, we do insulin. We're checking all the basic blood work. We look at your semen analysis, and we incubate your sperm overnight for 24 hours to see if it's still swimming the next day. If you have less than 56% swimming the next day, you have less than 3% chance of success with insemination. So we look at that for all of our clients. And then more and more, we are doing sperm DNA fragmentation testing for our clients as well. Very rarely we'll do additional testing if we can't figure out what's going on for the guys to see if there is oxidative damage in the sperm, if there is high level of reactive oxygen species there. You can look for infections in the sperm. And then I think it's iGenomics. Yeah, they have a test where they can tell what percentage of the sperm are chromosomally not normal. I don't find it very useful because at the end of the day, it's not like you get to pick the sperm and then determine how normal it is or not normal it is. It just is whatever it is, and you know, you're going to get whatever you get. But we do fairly comprehensive testing here. So normally when I tell a couple the guy's sperm looks okay, I'm saying it based on pretty comprehensive data that we're comfortable with at that point. If they have truly unexplained infertility, they've even done surgery, and you can't find anything wrong with the woman, it likely is a component of male factor that we can't diagnose. What percentage would that account for? Probably less than 2 or 3% of all the cases that we see. Maybe 5 maximum, but not very high. Good question.
Hi, Dr. Victory. It's lovely to see a Canadian doctor on YouTube. For egg freezing, does the length of priming affect outcomes? Would priming for a couple of days longer make any difference?
Okay, so if you're talking about priming with estrogen or something, or testosterone priming to do egg freezing, I would be very cautious. If you are needing to prime in order to get enough eggs, then someone has not told you the full story, because if you're priming, it typically means your ovaries are weaker, and egg freezing is incredibly dependent on your age. So if your ovaries are behaving like they're much older than they actually are, you're really going to fall into the same category for egg freezing as women that are freezing their eggs when they are older. To give you an example, when you're over the age of 40, you need over 60 eggs to freeze in order to just get one live birth. So it is not always necessarily reasonable to freeze your eggs if you do not have a high ovarian reserve or your age is not relatively low. I had one client who had seen a place in Toronto where she was 42 and they had said, yeah, come in and freeze your eggs, because she wanted to. And then they only got 7 eggs, of which I think only 4 were usable. That's absurd. I mean, the chance of that working out is negligible. And that is horrifically unfair to that person, not just financially, although that's a huge part of it, but emotionally, I mean, psychologically, it is, damning to that person to do that to them. So that is really, really inappropriate care as far as I'm concerned. And those patients deserve to hear the truth. And the truth is that if you're requiring priming for strengthening of your ovaries, then that's a problem as far as, how you're going to do, because you will need a lot of eggs. And it won't work. So you could be wasting your money. If you're talking about just lining up your follicles, like with birth control pill, just to get them all the same size, that does not make a difference whether it's a shorter period or a longer period. Although there are some studies that show that with birth control, the longer you're on it, the more suppressed you can be. And certainly if you get oversuppressed, you won't make as many eggs. So that may play a role. Next question.
Hi, Dr. Victory. Hope you can remember me. I had the stimulations of 22 days.
Yeah.
Actually, I had 2 back-to-back stimulations. One was 20 days, and another one was 22 days long. Oh my God. Now I have a very low AMH, 3, and a poor responder to IVF meds. Right. On day 12, my largest follicle is about 9 millimeters. My right ovary never responds, making only 1 follicle with the meds. Do you think I am a good candidate for natural cycle considering my low AMH, endo, and poor response?
Yeah, so I do remember you from last week when you mentioned that to us. So if you are getting a 22-day cycle, the chance of success is virtually 0, unfortunately, for multiple reasons. So number 1, the egg quality will not be good. Number 2, there are undoubtedly genetic and epigenetic changes going on in the DNA of your egg, which are not helpful. And then number 3, and we've presented on this before, there is something called smooth endoplasmic reticulum in your cells. If any of you remember that from biology, I'll be very impressed. And that's where proteins go to have some processing done to them. The smooth endoplasmic reticulum will tend to clump together when you're on stimulation for more than even 12 days. So once it starts to clump together, the chances of success are heavily compromised. They're very detrimental. So it does not make sense at all to go 22 days. And quite frankly, anyone that's trying to do that to you is not doing any service to you at all. Realistically, those are cases where natural cycle IVF does make the most sense for the situation. But I would have to caution you that even that is going to have a very low chance of success if your ovaries are that weak. So go into it understanding what your chances are. I would have to talk to you personally to figure that out. And I think you tried to reach out to us through Facebook. So just go onto Instagram, go to rahivictory.md, and then send me a private message or a direct message. That's the DM we were referring to. And I will happily address it with you. But realistically, we would need you to get a consult through the office, and then I can talk to you one-on-one. And the bottom line with all of that is that you need to be very, very cautious. Clearly, you're going to be a much better candidate for doing egg donation. But if you very much want to try your own, I would never try anything other than a natural cycle for you. And that depends on the length of your natural cycle. If you're having a natural cycle in, 28 days, 30 days, it would be crazy to give you meds and make it 22. That just makes no sense whatsoever. I would just let you do it natural, pick up the egg, turn it into an embryo, see what kind of quality we get. So message me for sure.
Thank you, Victor. Thank you. Thanks for all you do, Dr. Victory.
You're welcome.
Do you automatically opt for every assisted hatching for every FET you perform? Is it something you recommend for a greater chance of success?
My embryologist makes that decision by looking at the quality of the embryo. We frequently will do assisted hatching because it does make it easier. The research out there is equivocal. There are some studies that support its use. There are other studies that don't. We do it most of the time. You certainly have to do it if you're doing pre-implantation testing. For everybody else, it's optional unless their age is advanced, they've had multiple previous failures, or they've got a very thick zona. So there are some criteria where it has been shown to be beneficial. For the rest, we normally do it, but not always, and it's a case-by-case decision. So we decide for each and every patient.
What causes an ectopic or pregnancy in unknown location? No history of any infections. Is it indicative of poor egg quality?
Indicative? No, to the best of our knowledge, ectopics have nothing to do with egg quality. Number one problem would be previous infection, chlamydia or gonorrhea, and keep in mind that 40% of those infections can be unknown or what we call silent. So number one problem would be that. Smoking is a risk factor, previous pelvic surgery or any kind of infection, including like appendicitis. Endometriosis is a risk factor. But there is a baseline percentage of patients that just get an ectopic with zero risk factors. We don't know why that happens, but it does. And so it is not known to be a risk factor for poor egg quality. In fact, if anything, to be honest, the vast majority of our patients that have ectopics end up getting pregnant again without problems. So it should be fine.
We have a question poll. We have a poll that we're asking them.
Okay.
What part of the world are they watching from?
Oh,
Canada,
cool.
America, or?
Yeah, so we got a poll up that Target's put up for us saying what part of the world are you watching from. So click on wherever you're from. We want to know where you're watching from. We have people calling us from Australia all the time. That's a growing group for us. All over Canada, we're really proud to serve. We've got clients coming to us from the US now because we're so much cheaper than they are over there. And all sorts of people coming from all sorts of different directions for us to help them. So Europe, a lot of Europe. So yeah, let us know where you're watching from. We're super keen to find out. And I hear we've become quite famous in Iran lately, actually. Apparently, they watched one of our videos. No, actually, that's the funny thing. They were not watching that. So someone told a Persian physician to watch our show, and they watched it, and then they showed it to all of their friends. And so now all of Tehran is apparently obsessed with all of our videos. So I thought that was pretty cool. Yeah. Yeah.
That's great.
Hopefully it'll distract them from doing the crazy stuff they normally do.
Yeah.
All right.
So should baby aspirin be taken during Stim phase?
Yeah, you certainly can take baby aspirin during the Stim phase. Does it increase your risks of bleeding at the time of retrieval? Probably. But there are some safety benefits. It will increase your blood flow. So We don't use it for women that have like really strong ovaries, but for women with weaker ovaries, we do, because it'll improve their blood flow. And of course, if you're jabbing the ovary less, then there's less risk of trauma. So it's a reasonable thing to consider.
So the poll so far, because we have an election here in Canada, so we're having our own vote going on here.
We got our own vote.
43% of the people are from Canada.
Okay.
43% of the people are from the US.
Wow.
Yeah.
Cool.
And we got a huge 14% other. So I'm asking, what's this other? Where are these guys from?
That's cool. Hey, if you're the other, well, thank you to everyone who watches. We love the fact that you're watching. If you are from the other, I would love to know where you're watching from. That would be super interesting. Mexico, South America? It's got to be in our timeline. I mean, it's the middle of the night.
I'm dying to find out.
Yeah. I guess it'd be morning in Australia. So maybe some of the Aussies are watching this.
Top of the morning to you.
Top of the morning, yeah.
Hi, my doc has me on 50-50 ratio of gonal F 225 and Menopur 225.
Perfect.
What's the benefit?
So there's a British study that showed that the best outcome from a genetics standpoint, in other words, the highest number of euploid or genetically normal embryos would be derived from having a 50-50 ratio of what's called recombinant, which is a synthetically produced FSH, like gonal F, to urinary derived, which is Menopur. So we do the same thing, 50-50 mix. We've kind of pioneered that for a long time. And you're doing the right thing. That is a fairly high dose. It's kind of one of the upper doses we use. But it is a reasonable dose for many instances in many cases. So yeah, I'm supportive of that. That's a reasonable approach to things. The benefit is you're trying to maximize the quality of the embryos that you're getting. And as a general rule, gonal F for a long time has been established as kind of the leader for the strength of its response. And Menopur has kind of created a little niche for itself as giving the best quality. So if you want the highest number of eggs with the best quality, you blend the two. Yeah.
We have a result from one of the others.
Oh yeah, sure.
Sweden.
Oh my God, it's got to be 3 in the morning in Sweden.
With sick kids in the middle of the night.
Wow. Hi, Sweden. I would love to go to Sweden. I read a lot of Swedish crime thrillers. I don't know why. But I got into it after the Girl with the Dragon Tattoo series. Great literature. So yeah, that's super cool. I'm sorry your child is sick. Our thoughts and prayers go out to you. So thank you for watching, and I'm glad you're there. Share with your friends. That would be so cool. We should do like the Swedish edition sometime. I don't speak Swedish, but maybe we could get someone to translate.
D-dimmer test came back, elevated at 900.
Woo.
Well, I am 19 weeks pregnant and have back pain. Is this alarming or monitor for symptoms of a blood clot?
No, D-dimer in pregnancy is naturally elevated. I don't know who did that for you, but it's a waste of time.
Always a good answer. Hello, Dr. Victory. Curious how much PIO you use as well as suppositories for FET.
50 milligrams of PIO per day. And we use, depending on which progesterone, different doses. So if it's prometrium, 200 3 times a day vaginally. If it's crinone, 1 applicator twice a day. And if it's endometrium, 1 tablet 3 times a day as per the instructions.
Hi, can you please explain what a low mosaic embryo means? What are the chances of getting pregnant with this type of embryo? Thanks.
Okay, so when we do PGTA, which is pre-implantation genetic testing for aneuploidy, we are biopsying the portion of the embryo that is going to become the placenta. We're not biopsying your actual baby because that would be harmful. We're just biopsying the portion that becomes placenta. So when we send those cells off, they're amplifying the DNA and then analyzing it. So a mosaic means that some of the cells were normal, meaning 46 matched chromosomes or 23 pairs. And a mosaic means that some of the cells were not normal. So you're either missing a piece or missing a whole chromosome or had an added piece or an added chromosome. So you get a mixture of normal cells and abnormal cells. When it's below a certain threshold of percent of abnormal cells, they call it a low-level mosaic. And so they've done various studies, including one that was done not too long ago. And I didn't really know if you guys would ever be interested in this because it's super technical, but I can present the study next week if you like. Maybe send us some thumbs up if you want us to do the mosaic next time. So for those of you that want to know about that, there was a study recently where they blinded the doctors to whether or not the embryos were mosaic or were normal. So the doctors didn't know if it was a normal or a mosaic embryo. And they transferred them in and then looked at the outcomes. And there was no difference in the outcomes between the group with the mosaic embryos and the group with the genetically normal embryos. They actually had the same number of live births. So now we're basically telling people, if you have a low-level mosaic, you're going to get a reasonable outcome. It'll be basically 50-50, which is reasonably the rough estimate of what you would get if you put in a genetically normal embryo. Now, granted, our success rate here is a lot higher than that, so I'm not sure we're going to see the same success rate we get with a euploid embryo that we would with a mosaic, but at least it's 50-50. So you still have a decent chance. So now, in the past, we used to tell our patients, you can't use your embryo, but now we're actually telling them that they could. So I think that's important to know, and that's the whole thing about low-level mosaic. What's the actual chance? It's basically 50-50. Depends on your age and a bunch of other factors, but you got a pretty reasonable chance it's going to work.
You got tons of
thumbs up
likes for this thing.
For the mosaic. Mm-hmm. All right, next week we're going to do that study on the mosaics. I'll have to look it up.
Yeah.
We got to get Andre.
Let him do something.
We're going to make him do something. All right.
Hi, Dr. Vickery. What testing would you recommend for back-to-back pregnancy loss? Agreed TTC for 3 years. First one was 8 weeks loss. Second one was chemical. Stage 3 endo and hypothyroidism. So after not agree.
Okay, so first I'd look at your thyroid very, very carefully, especially if you have antibodies, you need to deal with those. You need to have your thyroid level checked constantly. And then there's a whole sort of spiel on recurrent pregnancy loss. So 2 back-to-back losses is a reasonable time to start investigating. So there are genetic causes where you look at your genetics and your partners. Infectious causes in you, so we use fertility and swabs. We look for your immune system. We look for whether or not you have a thrombophilia. We check all of your hormones. We look at your weight and your body mass index. We look at your vitamin levels, make sure those are appropriate. Cholesterol, sugar, those are really important as well. And then we make sure that your progesterone levels are adequate. We check the shape of your uterus, make sure there are no polyps or fibroids. All of these things are hugely important. If you've ever had damage to your fallopian tubes, i.e. stage 3 endo, it may be important to remove your tubes, because if the tubes are filled with fluid, that fluid is actually toxic to embryos and can prevent embryos from continuing to grow. If it's male as well, or if you're thinking you're normal and it's male-based, we always now check for DNA fragmentation. On top of that, we got to check all of your social habits for you and your partner. No smoking, no drinking, no drug use whatsoever, including marijuana. So those are the things we check, and we're really kind of very detail-oriented when it comes to recurrent pregnancy loss. My heart goes out to all of you who are suffering with that, and so I like to make extra sure that I've checked every single thing. I've dotted every I, I've crossed every T.
Hi, Dr. Victory. I was a patient about a year ago and wanted to get an appointment, and was told I need to get a doctor referral. But how can I get it if a lot of clinics are full? Thank you.
You can just go to a walk-in clinic if you need to get to see us. It's one of the glitches of the Canadian healthcare system. We're not supposed to really see patients without a referral. So you just have to go to the walk-in clinic and just say, I want to go see Dr. Victory, and we are happy to take you back. If it's urgent or something like that, reach out to the office and just say, hey, it's urgent. Is there a way you can help me? We do have a family doc working with us, so you can always see her without a referral, and then she will refer you on to me if need be. So you can come directly to us now through our family physician, Dr. Carrie Miran. And she's amazing. I love Carrie. So I trained her for months and months. when you talk to her, it's exactly like talking to me, but she's sweeter.
Should we stop DHEA during Stim?
No, you stop DHEA when you trigger. You don't want to take it after trigger because it's pointless, but up until trigger, you can stay on.
I got a big one.
A big one. All right.
Hi, Dr. Victory. I did 2 IUIs on May and July. That was not successful. Ones, and I'm waiting for another IUI before I head to IVF. But as I just had my period for only 1 day, and that too was scanty, I was prescribed hydroxyprogesterone by Lisa, and even after that, my period didn't show up, and she recommended me to take birth control pills, which kind of scares me as I get very sick on those OCP hormones.
Sure.
I told her I would probably exercise or take acupuncture to bring on a period, but this time neither of them are working. Usually I get my period with acupuncture before. What do you suggest me now to make my period come? Just to mention, I am diagnosed PCOS and have an AMH9. I respond very good on 5 days, 7 milligrams letrozole with very good follicle size, but never got pregnant. And my tubes are patent with very good quality swimmers from my husband.
So birth control actually is very reasonable, but you could actually just take your letrozole and see what happens. You don't necessarily have to have a period, although it's kind of helpful to clean out. So if you take the progesterone for 10 days, whether or not you bleed is not hugely important. You can then start right into your letrozole and you should be fine. I would get us to check your hormones again. So just let Lisa know and she'll set up to check your hormones and make sure it's okay.
Is mini IVF better than paying for full price IVF? 35 secondary, unexplained infertility, only desire one more child.
So if you look at the studies, most of them will show you that mini IVF does not make a huge difference from a standard IVF cycle. If you're only 35 and you've got good ovarian reserve, you don't need a ton of eggs. So I would say many would be fine. It depends though. If you've got weaker ovaries, you may need more eggs to get a good outcome. So you need to really talk to a physician that cares and listens and does the right thing for you. But in that particular circumstance, I'm not a huge fan of mini IVF, but I'd actually advocate for it in that particular circumstance, especially if you're worried about having a lot of leftover embryos. It would be entirely reasonable to do that. Yeah, try it out. But make sure you know all the details about you. So your AMH level, your antral follicle count, how strong your ovaries are, all of that's important.
How successful is FSH for male factor?
Well, you typically start with Clomid or HCG, and then if that's failing, you're moving on to FSH. The studies show that it can rejuvenate the testes, but it can take a long time, sometimes even up to a year. And at that point, you're never going to be great, but you might make enough sperm to at least do IUI or IVF. So it's a reasonable approach to things. You got to be very, very patient. And depending on the age of the woman, that's not always medically appropriate. So it can be a bit variable.
During the FET cycle, should I take melatonin? If yes, when should I start and stop? And what dosage?
3 milligrams, start before, don't stop till you're done with pregnancy. Easy. Next.
Is there a correlation between embryo grading and implantation, ongoing pregnancy of euploid embryos?
Do you realize you're gesturing?
I feel like the question demanded it. Is there a correlation? I was correlating.
Is there a correlation between what?
The hand's distracted, eh? Is there a correlation between embryo grading and implantation, ongoing pregnancy of euploid embryos?
Yes, we presented that 2.5, 3 months ago.
Yeah, I want to say 3 months.
Was it 3 months?
I think.
Yeah, we did present that. So even if your embryo is euploid, if it's less than a BB grade, there is a decrease in success. So that is still important. Your morphology is still important, even when the embryo is euploid. It makes a difference. So you need to follow that for sure.
They're asking for the secret sauce.
The secret sauce.
What is the best practice protocol after an FET? Should I lay down right after? If yes, for how long?
Yeah.
And what should I do the week after the FET? Any advice, tips? Thank you.
Yeah. Do whatever stresses you out the least. So they do have multiple studies, including one that was published recently that shows that there is no difference with the amount of activity that you have after you have a frozen embryo transfer. So anything reasonable is reasonable. What we do recommend, though, is do whatever stresses you the least. So for the people that feel more stressed when they're exercising, when they're at work, don't go to work. And for the people that feel more calm when they're at work because they're busy and they're occupied and they're not thinking of, oh my God, I should jump on Google every 3 minutes for every twinge that I feel, those people should go to work. So if you're less stressed at home, stay at home. If you're less stressed at work, go to work. There's no difference in outcome based on your activity level.
Hello.
Hello.
Hope you are doing well.
Thank you, I am.
Are Centrum prenatals plus DHA a good choice? If not, what is better?
So we have a great video with our naturopath, Jennifer Strong, called The Good, the Bad, and the Prenatal.
Yeah, that's right.
The Good, the Bad, and the Prenatal. It's on our YouTube channel. I think it's one of our more popular uploads. It's got several thousand views on it too. So we broke down like 5 or 6 of the most popular prenatals. Centrum prenatal with DHA is good. It's not the best by far. So Pregvite and one called Prenatal SAP from a company called NFH are the two with the highest amount of vitamins in them. I don't advertise for any companies. I don't get any money for any of this. I'm just purely talking medicine here. So highest amount of the recommended daily source or intake of each vitamin is in those 2 particular brands. So those are the 2 best. And then it moves down into Materna and Centrum Prenatal, which are literally the exact same vitamin. And then from there, it moves down into some of the other ones like the Kirkland brand and stuff like that. Watch that video though. It's great. And Jennifer Strong is extraordinarily brilliant and knowledgeable about this stuff. So she's great.
Dr. Victory, my husband and I had an appointment with you this past Friday.
Okay.
Can we schedule an in-person visit to over the entirety of our next steps?
Yeah, for sure. If you want to be in person for your next one, just tell the office, no, we want to come in, and we don't restrict people from coming in now. So if you want to come and see us in person, we can. Or if you want to just Zoom, we can do Zoom. Whatever works for you guys, we're easy.
If my prenatal already has 35 milligrams of iron, should I assume that's adequate for preparing for FET, or should I use an additional iron supplement?
If you're low in iron, you should get something much stronger. The glycosylated iron formulations are much better for absorption and tolerance than the non-glycosylated kind, which are the majority that are in your prenatal vitamins. So examples would be Palifer, Eurofer, Triferex, Ferromax. I think those are the 4 main ones. Yeah, so if your iron is low, if your iron's not low, for now you don't need to worry about it, although everyone's iron dips in the pregnancy because babies are great little parasites and they suck it all out of you. So yeah, you'll need more probably during the pregnancy.
Hi, my favorite doctor.
Oh, thank you.
I'm almost measuring for my IUI, most likely this weekend based on my CD9 measurements.
Okay.
I'm recovering from a UTI currently.
Okay.
Due to my history of preterm labor and losing the baby last year, 24 weeks, due to a possible infection, should I start a round of antibiotics? What doing the IUI for precaution?
Well, if you have a urinary tract infection, you should take antibiotics. There are studies that go both ways as far as antibiotics are concerned. I have seen studies that show that there's an increased rate of miscarriage, not preterm labor, with antibiotic use early in the pregnancy. And I've seen studies that say that there's no difference. In fact, there was just one recently I read that said there was no difference. So you're probably better off taking it because the last thing we want is for you to get sick from a kidney infection, and your bladder infection can go up into your kidneys and get you very ill. So if you need to, take your antibiotics. That's critically important for you.
Just wondering what your opinion is on low dose stimulation cycle.
Yeah, we just talked about that for a mini IVF. So a low dose stim or a natural or a mini have all been shown to be reasonably similar to a full stim. Most of the studies say within a couple of eggs, you'll be roughly the same. So it's a reasonable approach to things. I don't think I've seen yet a high dose protocol versus a mini and see what the differences in outcomes are. There was a great presentation at one of the conferences I attended in Chicago one year by a doctor from Harvard who went through the data and said, look, ultimately, the more eggs you get, the better. And he's right. I mean, the more eggs you get, the higher the chance of success. So the reason I don't do a lot of mini stim is because I've always followed that adage that the more eggs we get, the better. But it has to be appropriate. If you're dragging people out for 15 days to get more eggs, half the eggs are useless. So you've got to do it properly, which is more eggs is great, but it has to be within that 10 to 12 day time frame, and 12 days is kind of pushing your luck. So really 10 to 11 days, 9 to 11 days of stimulation time. That's a reasonable approach to things. So if you're doing the right thing in the right framework, it's good. If not, then you don't want to overdo it with the number of eggs. So mini stim's reasonable, or low dose stim is reasonable for certain people that aren't trying to make 50 different eggs.
So would you advise not to try again after having a C-section from an IVF success? Had to have it done as I stopped dilating at 9 centimeters and didn't progress any further.
No, I would absolutely advise that you do it again, but just be cognizant of the fact that it may make it more difficult. And honestly, that presentation is targeted more at people who are electively choosing to have a cesarean section. The studies didn't look at that. The studies just looked at people that had a section for any reason. But the reality is we want to deter people from asking for a cesarean section because those people end up compromising their fertility. So if you've had to have a cesarean section, like I said earlier, absolutely go ahead and try to get pregnant again. It may decrease your chances, but that's our job to check, double check, and triple check everything, and we do. So we always look for that divot in the C-section scar area called an isthmusele to make sure that it's perfect before we go ahead.
Is a lining of 7.3 sufficient for a FET day 5 embryo?
It's borderline. Many studies would say it's fine to be 7 millimeters. We like it a little bit thicker, but it's reasonable. And if you can't get it thicker than that, then we would go ahead.
What would you suggest for a woman who has had 2 failed FETs of euploid embryos, 1 implanted but no fetal pole seen at ultrasound, and 1 failed to implant? Embryo glue, HCG wash, PRP, intralipids.
None of those. I would advocate for full investigations of you first. So you need basically a recurrent pregnancy loss workup, thrombophilia screen, genetic testing of you and your partner, saline fusion sonohistogram, fertility testing for infections in your uterus, check your hormones, check your thyroid, in particular, check your thyroid, check your vitamin D level, your iron level, your B12, make sure you're not smoking, drinking, using any drugs, no vaping, no marijuana use. Make sure your body mass index is reasonable. You don't need to do a whole bunch of fancy gizmos till you actually know what's wrong. None of those things are going to work if there's an underlying problem that we haven't solved. So I love the fact that in the fertility world, people are always throwing expensive treatments at you without necessarily knowing what's wrong first. You need to know what's wrong. I mean, it might be something as simple as fix your thyroid and your problem is solved. It may be something that just has to take antibiotics for, like an infection in your uterus, or probiotics. So those are the things to do first. It's actually figure out what the problem is and why you're failing. If your fertility center is just saying, come back, we're going to throw in embryo glue, then they don't know what they're doing. So don't do that, because they're not helping you. They're actually helping themselves.
What are your chances of conceiving a baby each time you have an IUI if both man and female are healthy? Also, how many IUIs recommended before moving into IVF? Thank you.
So that question is very loaded, but it depends on your age. We do have a presentation going back probably 18 months ago now, looking at the number of IUI. What's that one called?
Title of that escapes me. 18 months challenges.
It's in our popular
But it's
uploads.
there. It is there. Yeah, it is.
Probably, you know what? I probably find it going through here. But anyways, it's in our popular uploads. So we talk about the number of IUI. So over 38, 39, 3, less than 38, 39, 6 is the total number. Your overall percentage of success in that particular study was roughly 30% when you were less than 38. And over 38, it was about 15%, 14 or 15%. So there is a big drop off when you get older. So per try, it's lower. And then again, of course, it depends. If you're in your early 20s, you're going to have a much higher success rate. And it also depends on the quality of the sperm. So some of these things are hard to answer without knowing all the details. But IUI is modest at the best of times. And that study, I believe, if I remember correctly, was from a Chinese group where they looked at thousands and thousands of cycles. So it was really robust data. So take a look at that. Whoa, God, I got to remember what it's called.
You have a lot of IUI videos.
It wouldn't be under search. It would be under, where was it? You know what? I could probably find it on my own. Okay, you ask the next question.
Okay.
I'll find it on YouTube.
Hi, Dr. Victor. Are there any studies showing the COVID vaccine and delay in periods or ovulation? Thanks.
There are no studies yet, although I think pretty much everyone will tell you that it is very likely that you will have some degree of compromise or alteration in your menstrual cyclicity. So there are a lot of women reporting that their menstrual cycle will change. And as a result of that, they will have a delayed menses for sure. Yeah. Okay, I'm going to find it now.
After a miscarriage of a new euploid embryo, now in a new FET cycle, as part of a new protocol, my doctor prescribed 1 Claritin for allergies and 2 Pepcid for heartburn. Why the heartburn tablet?
So the heartburn tablet, because it's an H1 blocker, which is a type of proton pump inhibitor, and they're trying to block both your H1 and your H2 in a essentially hopeful attempt to solve whatever fertility problem you're going through. The data on that is literally non-existent. There's almost nothing that tells you, basically that approach is useful. Our video is called "How Many is Too Many."
How many is too many? You're right.
Yeah. It was 10 months. I was off on the timing. It was 10 months ago. It's got me looking sideways. It says IUI right next to it. It says how many is too many. So check that out. It goes through the data. All right.
IUI. Oh, I like that one.
What time is it?
58.
58. All right. A couple more questions. Go for it.
Thank you so much for your dedication to this community. Finally got a positive beta today.
Yay.
And I credit my protocol modifications to you.
Oh, wow.
Thanks for the great advice.
Dude, we did it, man. Online, too. That's
that?
pretty cool. Congratulations from the whole community. That's awesome. I love those stories. Those are my favorites. That's amazing.
Fertility Blooms says, I get a ton of questions on mosaics. It would be a great topic.
Oh, okay. Hi, Crystal. Hope you're well. If you guys are out there and you are looking for fertility coaches, we now work with a couple of fertility coaches, one of which is Crystal and watching the show. And we also work with Melissa. So they'll be up on our new page shortly. I think Tarek's working on that now. Yeah. So we're going to have that added on to our, where do we decide to put that? The resource
center.
Right? Yeah. It'll be under our resources tab on our website. So check them out. They're amazing.
I wonder if there's long-term studies done on health of the mosaic children into the future.
Long-term studies, no, but keep in mind that those children are born euploid. Their own DNA is normal. It's the placenta that is abnormal. So the placenta can have mosaicism without the baby having mosaicism. So the babies are actually coming out normal. A mosaic baby would be potentially a problem, although there are people we find that are mosaics, but some of them have some very significant health issues.
What is a normal dose of spray for endometrius pain.
What is a normal dose of Cinerel for endometriosis pain? I don't use Cinerel, guys, so I'd have to look it up. I honestly don't know. It's more of a European drug. It's not used here very much.
It's the girl from Sweden asking.
Is it?
Yes.
Well, let's look it up for girl from Sweden. Yeah. Cinerel dose for endometriosis. God, I didn't think I'd be doing this tonight. A 200 microgram spray once in the morning and once in the evening for 6 months, I think it says. Yeah. 200 micrograms into one nostril in the morning and one spray in the other nostril in the evening. So that's another 200 micrograms for 6 months. So one spray in the morning, one spray at night for 6 months for endo pain. And that does work very, very, very well. But after 3 months, you should be taking add-back therapy to minimize chances of bone loss.
How many days into a cycle do you generally do an FET? What prep do I need to do in advance?
Lots of prep in advance, healthy eating, healthy diet, exercise, some soul searching, meditation, prayer, all that good stuff. Make sure you are calm. If you're not, use one of our resources to get calm. So social workers, psychologists, our online program called Organic Conceptions, naturopath, acupuncture, those kinds of things. And then lots of vitamins, lots of supplements. We go through this every show. Vitamin D, coenzyme Q10. You want to be on iron most of the time. Melatonin has been shown to be helpful. The omega-3 fish oils are also really good for you as well. We use letrozole for our protocol. We use steroids for 5 days. We use progesterone in oil and vaginal progesterone. We try and minimize estrogen exposure. You have to be on the progesterone for 5 days before the embryo is transferred. So you have to have completed 120 hours of exposure to progesterone. In other words, you should not have your embryo transferred prior to 120 hours from the first administration of progesterone. And it can go up to 144. So as long as you're anywhere in that range, you're good. And then measure your progesterone levels.
902.
One or two more.
Great to see you doing this. Thank you so much.
My pleasure.
I'm trying for baby number 2. After a successful IVF transfer, so far I've had the following. FET1, unmedicated, canceled because I've already ovulated. That's all she wrote.
Oh.
That's the question has vanished.
So if you just ovulate, we would just start again, and you just need more close monitoring. You may need Cetrotide to prevent you from ovulating. So you just need to be monitored really closely.
So many people are asking this question.
Yeah.
And I think you answered it, but since it's been asked 4 times, I want to ask you again.
Okay.
I apologize for this.
No, go for it.
Any vitamin or supplements I should be taking in preparation for my FET next month? Already taking a prenatal and vitamins.
Yeah, so prenatal, your vitamin D, extra vitamin D, and get your vitamin D level checked. Depending on your health background, there may be other supplements you need to take. We recommend iron, the omega-3 fish oils or fatty acids, and then melatonin. So those are the ones you should be on for your FET. Those are all hugely important. If you have thyroid dysfunction, inositol, selenium. If you have PCOS, NAC, inositol, coenzyme Q10. If you have endometriosis, you want NAC and you want curcumin and coenzyme Q10. So it all depends on what's going on.
A question labeled as a controversial question.
I think Andre just died.
Yeah, he tapped out. The charts are just all over at this point.
Yeah.
Are you seeing people in your office who are not COVID vaccinated?
Oh boy.
Sorry if this is too political.
We are seeing everybody in our office, and we are taking precautions as we should. So face masks, eye protection, so on and so forth. We do not allow partners in under general circumstances. We tend to try and avoid that as much as possible. So we are doing everything humanly possible to protect you and to protect us. I do want to say, however, because someone very near and dear to me is not currently seeing patients in the office who are unvaccinated. And I want to say that I fully respect that decision because everybody's health history is different. And if I was susceptible to the side effects of contracting COVID, which you can even if you're vaccinated. In fact, I'm now kind of higher risk for contracting Delta because I was vaccinated very early on because of being a physician, then I would probably refuse to see people too. And that's not anything against vaccinated versus unvaccinated. That's just me protecting me and my family. Now, do I need to do that personally? I don't, because I'm kind of pretty healthy and fit and I don't get sick that often. And I'm probably able to withstand, or at least I hope I'm able to withstand the COVID infection. I don't have any underlying health problems or any issues like that. So I don't have high blood pressure or heart disease or anything. But if I were someone that was struggling with some kind of health condition, especially one that is potentially going to compromise my health or put me at risk for COVID complications, heart disease, respiratory disease, significant immunological compromise, just even age, then I would be very likely to also refuse seeing people that were unvaccinated because you're placing me, my livelihood, all of the other patients who count on me at risk by showing up unvaccinated. So I don't believe we can force people to go get vaccinated, but I strongly advocate for everyone to go get vaccinated. Absolutely. All the mumbo jumbo out there about vaccines is totally patently false. There isn't a speck of truth to any of it. It's all just nonsense. And I also believe that you need to be respectful of the people who do not want to get vaccinated, but they then need to be respectful of the people providing them care, because you can't say, I don't want to get vaccinated, but I still demand that you care for me, when you're then putting that person at risk. It can't go both ways. If you're not going to get vaccinated, you have to appreciate the fact that you're going to limit the sphere of the people that can help you. I do want to say really quickly that more and more data is coming out, including a great article in the CBC the other day. I don't know if I can send it to you. You can put up the link.
I could.
So there's a great article in the CBC the other day, which I will try and post for you guys somehow, which showed that the chance of you ending up in the intensive care unit from a COVID infection is 10 times higher when you are unvaccinated and you get pregnant and then you get COVID. And the risk of death, we already know, is 22.3 times higher. So I'm sending it to you here, T. So there is absolutely no question that these risks are gigantic and very, very, very frightening. So risks of preterm labor, 300% higher. Risk of stillbirth, 400 and something percent higher. Risk of preeclampsia, 400 and something percent higher. Admission to ICU in one study, 400%, and another study over 1,000%. Risks of death, 22.3 times higher. That's 2,230%. So no matter what your feelings are about the vaccine, now that hundreds of millions of doses of vaccine have been administered, the risk of an adverse outcome is maybe a fraction of a fraction of a fraction of a fraction, right? So let's say at its highest, it's 1 in 1,000, okay? If it's 1 in 1,000 chance of something bad happening compared to a 2,230% increase in your risk of death, no one should be going unvaccinated when they are trying to get pregnant. No one. There is absolutely no logical reason anybody can give me to avoid it. And it has zero impact on pregnancy. And that has now been published in 3 separate studies, not funded by the drug company and all that nonsense, 3 independently verified studies. So there is no question that if you are out there either trying to get pregnant or pregnant, you must get vaccinated. It is lunacy not to, because you are actually jeopardizing the life of your child. And that is irresponsible for everybody. So please, 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 please go get vaccinated and get your partners vaccinated. And everybody get vaccinated. There are no microchips in it. It does not compromise your fertility. There is no biological mechanism by which it can get to your baby. So just go get vaccinated. I think that's a good one to end on.
Mm-hmm.
All right. Thank you very much. Thank you, Sweden. Big thumbs up for Sweden, everybody. Let's give Sweden a thumbs up. Hopefully your child is doing better. We probably bored them to sleep with our presentation tonight. So listen, we love having you all here. Totally look forward to having you all again next week. And you guys have a great evening. We'll look forward to seeing you. And see you next time on Fertility Fact or Fiction. Take care.